Imagine waking up tomorrow to a presidential address, confirming that we are not alone in the universe.
Wow. Yeah.
Like, the government has definitive proof of non-human intelligence.
Right.
Now, imagine you are a clinic director. An hour after that broadcast, your phone lines just completely light up.
Oh, absolutely.
You have hundreds of patients experiencing complete ontological collapse, like their fundamental understanding of reality has just shattered.
Yeah.
So how do you treat a reality-altering event that isn't technically a delusion?
Well, you are immediately forced to distinguish between a natural psychological reaction to an unprecedented macro event and an actual acute psychiatric crisis.
Which is huge.
It is. And historically, I mean, the clinical field has had absolutely zero framework for making that distinction at scale.
Welcome to the Deep Dive.
Glad to be here.
Today, we are speaking directly to you, the clinic directors, the behavioral health professionals, academics, and institutional communicators navigating this totally uncharted territory. Our mission today is to take an abstract, almost, science fiction premise and translate it into a highly practical clinical framework.
Exactly. We really need that framework.
We are unpacking a June 2026 executive briefing. It's titled The Psychological Impact of UAP-NHI Disclosure.
Right. Published by the Disclosure Foundation.
Yeah, and authored by a massive multidisciplinary team, Janice Vilhauer, Tim Lomas, Daniel Stubbings.
Omer Eldadi's on there too, right?
Yep, Omer Eldadi, Thomas Rabaran, and Gabriel G. Delatorre. They have essentially written the first survival guide for the human mind during a planetary paradigm shift.
And, the real value of this briefing is that it treats disclosure not as some philosophical thought experiment, but as an impending public health reality.
Right. It's practical.
Exactly.
Right.
Because we are currently navigating a really significant clinical response gap. For decades, I mean, the mental health community has inadvertently contributed to this gap, mainly because of the pervasive stigma surrounding unidentified anomalous phenomena.
Okay, let's unpack this. Let's look at the timeline of this event, because that timeline dictates how that clinical gap is going to widen or hopefully close.
Yeah.
The report emphasizes that disclosure isn't just, a single cinematic moment where a spaceship lands on the White House lawn.
Right. No Independence Day scenario.
Exactly. It is a staged, unfolding escalation.
Yeah.
And we are actually already in stage 1, which they call limited disclosure.
Yes.
That's following the February 19, 2026 presidential directive ordering federal agencies to release classified UAP records. So the government acknowledges the phenomena, but the info is still really ambiguous.
And that ambiguity is the defining characteristic of stage 1.
Right.
But consider the psychological load on a patient as we move through the subsequent stages. Like stage 2 is confirmatory disclosure.
Okay.
That's where authorities officially state that these phenomena are just not of known human origin.
Oh, wow.
Yeah. Then we hit stage 3, attribution disclosure, which is the actual revelation of an associated non-human intelligence.
That's the big one.
It is. But then stage 4 is reconciliation disclosure. That's where the public learns the historical reality.
Like the cover-ups.
Exactly. Past interactions and what's been concealed for decades. And finally, stage 5 is full integrated disclosure, where the presence of NHI basically becomes a permanent fixture in our science, technology, and economy.
So instead of just listing those stages, let's look at what that escalation actually does to, say, a patient sitting in a waiting room.
Yeah, let's ground it.
Right now, in stage 1, a patient experiencing anomalous events might just feel gaslit by the news cycle. But what happens to that same individual's mental state when we hit stage 4, and the government essentially confirms that the reality they were previously mocked for is actually true?
Well, we see this fascinating psychological paradox. The report points out that available evidence actually does not indicate UAP witnesses are psychologically dysfunctional.
Wait, really?
Yeah. They are, by and large, completely psychologically healthy individuals. The clinical distress they experience is rarely caused by the anomalous event itself.
So what's causing the distress then?
It's primarily driven by the societal reaction, the ridicule, the dismissal, maybe losing their job, and just profound social isolation.
Right.
The authors use the term pluralistic ignorance to describe the social mechanics at play here.
Okay, let's pause and define pluralistic ignorance for the institutional communicators and clinic directors listening who might not be super deep into sociological terminology.
Sure.
That is when everyone privately rejects a social norm, or in this case, privately believes in or is just curious about UAPs, but they assume everyone else completely accepts the stigma, so they self-censor.
Precisely. Everyone stays quiet because they think they're the only one in the room who believes it.
Wow.
And this self-censorship creates just a profound sense of isolation. So when stage 4 hits and truth is reconciled publicly, the psychological burden on these individuals shifts. They're no longer dealing with the trauma of an anomalous experience. They're dealing with the trauma of prolonged systemic betrayal.
Man. Okay, so if distress is largely driven by stigma and systemic isolation rather than the UAP event itself, I mean, doesn't that fundamentally shift our entire clinical approach?
Totally.
We aren't treating a delusion anymore. We're treating profound social alienation.
Yes, exactly.
So what does that actually look like on a Tuesday afternoon? Like if a patient sits on my couch and says their reality has been upended by these government disclosures, how do I validate their ontological shock without inadvertently validating a potential underlying paranoia?
Well, it requires a fundamental pivot in the therapeutic alliance.
Sure.
The clinician just has to normalize the distress.
Okay.
The mechanism here is moving away from immediate pathologization. You validate that feeling completely disoriented during an unprecedented macro-societal event is, well, it's a healthy adaptive response.
Yeah, that makes sense.
You're helping them process the friction between their personal experience and society's shifting narrative, rather than trying to, cure them of an anomalous belief.
That leads directly into how diverse internal belief systems are going to process all of this.
Wow.
Because we are talking about a massive ontological shock.
Massive.
The report maps out a continuum of psychological responses. On one end, you have people reacting with positive engagement and curiosity. Moving along, you find neutral compartmentalization, then active adjustment, which inevitably bleeds into anxiety and resistance.
And that resistance phase is where cognitive dissonance really reaches its peak.
Right.
Cognitive dissonance isn't just a feeling of mild confusion, it's a literal physiological stress response.
Wow.
When your core beliefs are challenged, the brain's threat detection center, the amygdala, activates exactly as it would if you were facing a physical predator. It dumps cortisol.
Geez, so it's a physical reaction.
Yes. And to reduce that intense discomfort, individuals often resort to extreme skepticism, motivated reasoning, or just flat-out rejection of the evidence, simply to regain a feeling of narrative control.
And if that coping mechanism fails, the continuum darkens, right? The report notes that individuals can slip into severe mental health vulnerability, particularly if they have pre-existing conditions.
Exactly.
And on the absolute furthest end of that spectrum is catastrophic framing.
Yeah, catastrophic framing involves extreme despair and basically a complete loss of reality testing.
Okay, let's define loss of reality testing for our listeners.
Sure. Loss of reality testing is the inability to distinguish between internal fears or thoughts and the external objective world.
Oh, I see.
The person loses the capacity to evaluate what is actually happening versus what they are terrified might happen. In the context of NHI disclosure, this looks like adopting apocalyptic narratives, believing the world is literally ending, or experiencing acute psychotic breaks just because the cognitive load of the new reality is too massive for their psychological infrastructure to bear.
That makes total sense. So how do existing cultural and religious belief systems function as that psychological infrastructure? Because that feels like the most critical variable here.
It is, and the data on this is highly revealing. The report cites a 2025 international survey involving over 6,000 participants across, I think, 112 countries.
Wow, that's broad.
Yeah, and it found that 95% of people already believe intelligent extraterrestrial life exists, with nearly 63% expressing definitive conviction.
I really want to focus on that 95% figure. It's like updating a computer's operating system.
Okay, I like that.
If the religious or cultural hardware is already compatible with the concept of non-human intelligence, which 95% are, the update is smooth. The system just integrates the new data files. The crash-like, the catastrophic framing we just talked about, only happens when the new data fundamentally contradicts the foundational code of the user's reality.
That analogy perfectly illustrates the mechanism of adaptation.
Yeah.
Yeah. For the vast majority of the global population, confirmation is merely a shift in certainty, not the introduction of a completely alien concept.
Right.
And regarding religion specifically, the briefing shows that theological frameworks often protect against ontological shock.
Interesting.
A religious narrative provides a ready-made structure for processing the unknown. It might be framed in spiritual or prophetic terms, But that framing actually mitigates the cognitive dissonance.
Wow.
Most individuals report that NHI confirmation would not undermine their faith, it would simply expand their theology.
Okay, so the two factors the report identifies as the strongest determinants of psychological impact are perceived threat and personal relevance.
Exactly.
If someone believes the NHI is hostile and they believe it affects them personally, their cognitive load just maxes out. Knowing that these reactions will fall across a broad spectrum, we have to look at the systemic impact. Like, what happens when this entire continuum is activated globally all at once?
It's a huge issue.
Because stage 3 and stage 4 are not going to be gentle rollouts.
No, they aren't. And this is where we really must define the true public health risk. Media representations of disclosure always default to mass panic.
Oh yeah, riots in the streets, total societal breakdown.
Exactly. But the epidemiological reality, according to the report, is entirely different. The primary threat is not panic. The primary threat is concentrated demand.
A surge.
Yes.
Let's make this tangible. It's like how coastal hospitals prepare for a Category 5 hurricane.
Right.
The hospital doesn't expect every single resident of the city to be physically injured. But if even 5% of the population needs acute medical care in the exact same 48-hour window, the physical triage system just collapses.
Exactly.
People die not from the storm, but from the lack of access to care.
And that is the exact mechanism of a behavioral health surge. Even if only a modest proportion of the population experiences significant difficulty processing disclosure, when those needs emerge simultaneously across the globe, it will completely overwhelm behavioral health clinics, emergency psychiatric services, and community support lines,
which are already strained.
Critically underfunded and operating near maximum capacity already. That surge is what transforms a societal revelation into a public health emergency.
So what does this all mean for clinic directors listening right now, like mapping out their Q3 and Q4 strategies? It sounds like we shouldn't be prepping for doomsday, but rather for a sudden, massive spike in routine anxiety and profound, meaning-making crises.
Spot on. You must build scalable capacity.
Okay.
On a macro level, the report advocates for a national psychological preparedness and resilience task force.
That makes sense.
But at the institutional level, it means integrating resources like the 988 Suicide and Crisis Lifeline, emergency psychiatric services, and mobile crisis units into a unified, really flexible response plan.
Right.
You need protocols that allow you to temporarily expand access to triage and short-term stabilization support during periods of intense concentrated demand.
And we can't just, throw more therapists at the problem if they don't actually know what they're treating.
Exactly.
The authors outline specific training needs. Clinicians have to be trained to address uncertainty-related distress and ontological disruption. But what does a training module on meaning-making or ontological disruption actually teach a therapist to do?
Well, it teaches them to map the patient's shattered worldview and help them construct a new one. The training focuses heavily on narrative therapy and cognitive flexibility.
Okay.
Therapists learn to guide patients through the process of integrating transformative, anomalous information without pathologizing the experience itself.
Right, avoiding that trap.
Right. If a patient is deeply unsettled because their government just admitted to possessing non-human craft, the therapist must be trained to recognize that as a rational adjustment reaction to an extreme macro event.
Yeah.
Not the sudden onset of a delusional disorder.
And that specific distinction, separating a rational adjustment reaction from pathology, is the bottleneck, where we will either save lives or cause immense psychological harm.
Without a doubt.
But clinics can only absorb so much of the surge. The real question is how institutions and public health systems can actively lower that surge curve before it reaches the therapist's office.
Yes. Lowering the curve really relies on fostering resilience before the crisis peaks.
Right.
Because resilience is not a fixed personality trait. It is a dynamic capacity that can actually be engineered.
Oh, interesting.
The report identifies social connection, community cohesion, access to mental health support, and media literacy as the most potent resilience factors.
Let's talk about the mechanics of media literacy, because we usually think of it as just, spotting fake news.
Right.
How does media literacy actually prevent ontological shock?
It functions as a cognitive filter. When an individual has high media literacy, they have the analytical tools to slow down their emotional reactivity to sensationalized inflammatory headlines.
Okay.
They can separate the core factual disclosure from the speculative, threat-based framing that's often applied by media outlets.
Aha, I see.
And this cognitive buffering prevents the amygdala hijack we discussed earlier, reducing that immediate spike in anxiety.
And a massive piece of that resilience equation rests on institutional communication.
Absolutely.
The report defines clear best practices.
Yeah.
Early communication, transparent coordination, plain language, and trusted messengers. And it explicitly warns against delay, contradiction, and politicized framing.
If we connect this to the bigger picture, the overarching context here is the historical deficit of public trust in government institutions.
Right.
Institutional trust acts as the primary mediator for how disclosure information is metabolized by the public.
Yeah.
In a low-trust environment, people automatically discount official data, they perceive the threat as higher than it might actually be, and they seek out alternative, unverified sources.
Which just rapidly accelerates misinformation and social fragmentation.
Exactly.
The briefing makes a fascinating point, actually. The primary destabilizing factor for the public isn't the existential uncertainty of the UAP phenomenon itself.
No, it's not.
The destabilizing factor is the perception of managed ambiguity. It's the feeling of concealment, the feeling of being managed or betrayed by the institutions holding the information.
And psychological research bears this out consistently.
Right.
Human beings possess a really remarkable capacity to cope with difficult, frightening truths.
Yeah.
What we cannot cope with is prolonged uncertainty coupled with perceived deception.
Right.
When people feel they're being lied to, their ontological security collapses much faster than it does when facing a concrete known threat.
I have to push back on that, though. Institutions usually want to project total control. Let's look at recent global history. During the early days of major public health crises, like the COVID-19 pandemic, when institutions openly admitted they didn't know how the virus transmitted or what the true mortality rate was, it didn't foster calm.
Right, it caused panic.
Massive panic.
Yeah.
Hoarding. The immediate birth of conspiracy theories.
Yeah.
So why would an intelligence agency standing at a podium saying, we have non-human craft, but we have absolutely no idea what their intent is, increase trust? Wouldn't that terrifying ambiguity drive the public straight into the catastrophic framing the report warns about?
It's a really vital distinction to make. Admitting uncertainty can cause acute anxiety, yes, but offering false reassurances that are inevitably disproven causes permanent systemic collapse.
Oh, wow. Okay.
If an institution manufactures a narrative of total control just to pacify the public, and that narrative is exposed as a lie during Stage 4 reconciliation disclosure,
Right.
whatever fragile trust remained is just obliterated.
Yeah.
The public then assumes the worst-case scenario is true, because why else would the government lie?
So the transparency itself acts as the anchor.
Yes. The report argues that uncertainty becomes manageable when it is met with radical honesty and context.
Okay.
If leadership clearly outlines what is known, what is unknown, and the specific steps being taken to find the answers, the public is enlisted as a partner in the discovery process, rather than being treated as a liability to be managed.
That is a critical operational mandate for any communicator listening.
Absolutely. Institutional integrity is quite literally as important to public health as the disclosed information itself.
Right. If you try to manage the narrative through omission, you are actively engineering the very public health crisis you're trying to avoid.
Precisely.
Man, we have covered an immense amount of ground today.
We really have.
Let's summarize the core operational takeaways for our academic and clinical listeners. First, you must recognize the clinical gap created by decades of systemic stigma. Understand that individuals reporting anomalous experiences are generally psychologically healthy, and their distress is primarily rooted in social isolation and parallelistic ignorance.
Second, you need to prepare your infrastructure for scalable surge capacity.
Right.
You are not anticipating chaotic mass panic. You are preparing for a highly concentrated demand for meaning-making support and anxiety management.
Which means acting now.
Yes. This requires integrating emergency psychiatric services and mobile units now before the disclosure stages escalate further.
Third, prioritize targeted workforce training. Your clinicians must be equipped with the narrative tools to address ontological disruption and avoid the premature pathologization of rational adjustment reactions.
Exactly.
And finally, if you are in a position of institutional leadership, demand and practice transparent, coordinated communication. Honesty about the unknown is the absolute most powerful tool you have to foster societal resilience.
It really comes down to ethical responsibility.
Hmm.
As the briefing elegantly states, the measure of any society's response to extraordinary change is how well it protects those least equipped to absorb the impact. Safeguarding the psychologically vulnerable is not some secondary administrative concern. It is the central ethical duty of the behavioral health community as we navigate this transition.
Beautifully said. We have focused heavily today on how society and clinical infrastructures must prepare to shield the vulnerable from the shock of disclosure.
Mhm.
But I want to leave you with a different perspective to ponder as we close. We've established that the stigma, the profound ridicule, and the systemic isolation of UAP experiences have been the primary drivers of clinical distress for decades,
Right.
if that is true. Might the ultimate undeniable revelation of non-human intelligence actually serve as a profound moment of collective psychological healing?
Oh, wow.
For the thousands of individuals who have been marginalized, ridiculed, and forced into the shadows, could the very event that shakes the foundation of the world be the exact moment their reality is finally publicly validated?
The transition from isolated marginalization to validated reality,
Yeah.
that could be the largest collective therapeutic moment in human history.
It changes the entire paradigm of how we view the days ahead. Thank you for joining us on this deep dive. Keep questioning the framework, keep repairing your systems, and we will see you next time.